Welcome back to the deep dive. Today we're cutting straight through Chapter 45, Antivirals. We're going to find out why fighting a virus is, well, fundamentally different than fighting bacteria. We'll be mapping out the pharmacology you need to really understand the challenge of treating some of the most dangerous infections out there. So if you're looking for quick, high-impact knowledge in this field, you're definitely in the right place.
It is a profound challenge, yeah, because the enemy, lives inside your own castle, essentially. Bacteria are independent organisms, right? We can hit their cell wall or their metabolism, things like that. But viruses, they're obligate intracellular parasites.
Obligate intracellular parasites,
Yeah.
meaning they have to get inside our cells.
Exactly. They hijack your cells. So any effective drug therapy has to get into your host cells, target the viral replication cycle, and critically, do it all without being overly toxic to the host cell itself. That is the fundamental tightrope walk of antiviral pharmacology. It's really tricky.
So we're basically talking about disrupting that hostile takeover inside the cell. Okay, let's maybe establish the key terminology first. We often talk about the mature viral particle, the virion, and its core mission, which is replication. The drugs we use, they seem to fall into two broad categories: standard antivirals, and then those highly specialized antiretroviral drugs aimed at retroviruses like HIV.
That's right. And it's important to remember that these drugs are really just an assist to your own natural defenses. Your immunity is kind of divided into two major operations. You've got humoral immunity, that's antibodies from B cells,
Okay.
and then the frontline soldiers of cell-mediated immunity. Think T cells and macrophages destroying infected cells directly.
Got it. And to understand how the drugs work, we probably don't need to list all 6 steps of the viral life cycle right now.
No, not necessary for this.
But we just need to know that every drug we discuss targets one of, 3 main phases: either entry into the host cell, replication of the viral bits inside, or the release of the new virions to go infect more cells.
Precisely. Entry, replication, release. That's where the drugs interfere.
Okay, great. So let's unpack this first category then. Antivirals for non-HIV infections. So
Yeah.
we're talking about common things, right? Like herpes, influenza, CMV.
Yeah, the common culprits. These non-HIV antivirals are often synthetic compounds. They're designed to be nucleoside analogs.
False building blocks, essentially.
Yeah, exactly. Their main job is blocking a polymerase enzyme. They act as a fake piece during replication, so they suppress replication long enough for your own immune system to catch up and gain the upper hand.
Okay. Let's focus on herpes viruses first. HSV1, HSV2, VZV, chickenpox, shingles, cold sores, genital herpes. Our source notes that, interestingly, many herpes infections, like Epstein-Barr or even CMV in healthy people, often don't require medication unless the patient is immunocompromised.
That's true. But for an active outbreak of HSV or VZV, yeah, acyclovir is the standard go-to.
Right, acyclovir. Available in different forms too: oral, topical, injectable.
It's the gold standard. But there's a really huge clinical insight here regarding its prodrug, valacyclovir.
Ah, the prodrug. So it becomes active in the body.
Correct. Valacyclovir gets converted to acyclovir after you take it. And the big advantage is much greater oral bioavailability.
Okay, bioavailability.
Yeah.
Why does that technical detail matter so much for the patient, practically speaking?
Well, it's really about adherence. It's a win for adherence. Standard acyclovir might require, say, 5 doses daily, which is a lot to remember.
5 times a day, yeah, that's tough.
Valacyclovir, because it hangs around longer, allows us to reduce that to maybe 3 times a day, sometimes even less, depending on the indication. When we're fighting patient fatigue and complex regimens, fewer pills, less frequent dosing, that translates directly into better adherence and ultimately better outcomes.
Makes sense. Fewer pills, happier patients, better results. Okay, now for some of the heavier hitters, maybe, specifically CMV, cytomegalovirus, like CMV retinitis, which you often see as a complication in transplant patients or those with late-stage HIV. Here we rely on ganciclovir, right?
Yes, ganciclovir is indicated for CMV infection and also for prevention in high-risk folks. But this is where we hit a really serious clinical trade-off. Ganciclovir's major dose-limiting toxicity is severe bone marrow suppression.
Oof. Bone marrow suppression. That's serious.
Very, but then you have 2 related drugs, foscarnet and cidofovir, which are also used for CMV, and they are notorious for kidney toxicity.
Kidney toxicity versus bone marrow suppression.
Ah.
Okay, so for you, the clinician, let's say a patient is immunocompromised from an organ transplant. They might already be on powerful anti-rejection meds that are tough on the kidneys.
Very common.
Is the strategic decision then almost always to sort of tolerate the bone marrow risk with ganciclovir just to avoid pushing that patient's kidneys over the edge?
That's exactly the kind of clinical synthesis you need to make.
Yeah.
Have to weigh the patient's existing health issues, their renal function versus their hematologic status, and decide which organ system can, frankly, handle the hit better. It's a tough call sometimes.
Wow, okay. Moving on to influenza, the flu. We talk about oseltamivir, brand name Tamiflu, and zanamivir, which is Relenza. These are the neuraminidase inhibitors. What's kind of cool here is their mechanism, right? They stop the budding virions from actually escaping the infected cell and spreading.
Yeah, it's quite neat. They prevent the new virus particles from leaving the crime scene, as you said.
So they trap them inside the cell.
Effectively, yes. Which is precisely why that crucial clinical detail exists. Treatment has to begin within 2 days, 48 hours, of symptoms starting to be really effective.
Ah, the 48-hour window.
Exactly. If you wait until day 3 or 4, the virus has already replicated and spread pretty widely through the body. And the drug's effectiveness just drops off a cliff. The clock is always ticking with the flu.
Good to know. Then we have ribavirin. This one's described as broad spectrum, used in an inhalational form for severe respiratory syncytial virus, or RSV, often in hospitalized infants. But there's a huge safety alert here we absolutely have to highlight.
Yes, this is non-negotiable. Critical safety point. Ribavirin has severe teratogenic potential, birth defects.
Okay, so strictly contraindicated in pregnancy.
Strictly. For pregnant persons and also their male sexual partners, because the drug can be present in semen, and this warning even extends to healthcare providers who might be administering the drug in its aerosol form. You need precautions because of the risk of secondhand inhalation. This is an absolute safety mandate. No wiggle room.
Understood. Absolute contraindication. And finally, just briefly, we should probably note the recent additions, really accelerated by the pandemic, right? Remdesivir, a nucleotide analog,
Yeah.
and Paxlovid, which is that oral combination therapy, both now approved for use against COVID-19, but typically in specific high-risk patients.
Correct. Important tools added to the arsenal relatively recently.
Okay, so that the non-HIV section was maybe the simpler war. Now we enter the real chemical arms race. HIV and Antiretroviral Therapy, or RT. HIV being a retrovirus fundamentally changes the replication game, doesn't it? It forces us into these really complex lifelong treatment plans.
It absolutely does. HIV earned its name retrovirus because it uses these specialized viral enzymes that essentially reverse the typical flow of genetic information. And we target them all. There's reverse transcriptase, which makes DNA from the virus's RNA genome backwards from the usual process.
RNA to DNA, okay.
Then there's integrase, which helps insert that new viral DNA right into the host cell's own DNA.
Wow, integrating into our genome.
Yes. And finally, protease, an enzyme that acts like molecular scissors, cutting long protein chains that are made based on the viral blueprint. This cutting is a necessary final step for mature infectious virions to assemble properly.
And you mentioned reverse transcriptase. A big problem is that it's, well, kind of sloppy, right? It makes a lot of errors when copying.
That's a key point. It has a high error rate. And these frequent errors drive genetic mutations in the virus, which is exactly why drug resistance is such a constant and, frankly, terrifying issue with HIV. The virus is always changing.
Always mutating to escape the drugs. Okay, so what's the goal of modern RT then?
The goal is aggressive. It's usually a combination of at least 3 drugs from different classes if possible. And it's started immediately upon diagnosis. No waiting. This combination approach maximizes viral suppression and drastically reduces the chances of resistance developing.
Makes sense, hitting it from multiple angles.
Exactly. The primary clinical goal is achieving an undetectable viral load, usually defined as fewer than 50 copies of the virus per ml of blood. Achieving and maintaining that undetectable status is key to preventing progression to AIDS. And critically, it also means the virus is effectively untransmissible to sexual partners.
Yeah.
Undetectable equals untransmissible, or U.
That's a huge
100%.
message. Okay, let's step through the 5 major drug classes that target this unique life cycle. Focus on their mechanisms and maybe the major pitfalls or side effects.
Sounds good. First up, the reverse transcriptase inhibitors, the oldest class. These include NRTIs, nucleoside-tied reverse transcriptase inhibitors, and NNRTIs, non-nucleoside. They both block that essential RT enzyme. And zidovudine, or AZT, was the very first anti-HIV drug approved. It really taught us about a major dose-limiting risk factor with this class.
Which was?
Severe bone marrow suppression, anemia, neutropenia, a big challenge early on.
Right. Okay, second class.
Second are the protease inhibitors, PIs, like Indinvir, ritonavir, others. As the name suggests, they block that protease enzyme, stopping the final assembly of new virus particles. What's really unique or notorious about this class is a major long-term adverse effect. Lipodystrophy.
Lipodystrophy.
Fat redistribution, right. Exactly. It isn't just a cosmetic issue, though it certainly can be distressing. It's the redistribution of body fat. You might see fat loss in the face, arms, legs, giving a kind of skeletonized look, and fat accumulation in other areas, like the abdomen or the back of the neck, sometimes called a buffalo hump. And this is often linked to serious metabolic issues like dyslipidemia, abnormal cholesterol and triglycerides, and insulin resistance, potentially leading to diabetes.
Wow, so that side effect could become a massive barrier to adherence, couldn't it?
Yeah.
If the patient feels stigmatized by the physical changes or sees their body changing so drastically, they might just stop taking their life-saving medication.
That's absolutely right. It's a profound psychological and metabolic burden, and managing it or switching drugs as possible is crucial for long-term adherence.
Okay, third class.
Third, the integrase inhibitors, often called NSTIs, drugs like raltegravir, dolutegravir, these block the integrase enzyme, preventing that viral DNA from getting integrated into the host's human DNA, a very effective and often well-tolerated class.
Good. Fourth.
Fourth are the fusion inhibitors. There's really only one main one here, influvaxide. This one works differently. It physically stops the virus from fusing with the host T-cell membrane, blocks entry that way. It's an injectable, which can be a drawback.
An entry inhibitor. Okay, and the fifth class?
Fifth, the CCR5 antagonists, like Maraviroc. These are also entry inhibitors, but they work slightly differently. They bind to a specific co-receptor, CCR5, on the surface of the host CD4 T-cell. Some strains of HIV need to use the CCR5 co-receptor, like a second key, to get into the cell. So Maraviroc blocks that keyhole. You actually need a special test first to see if the patient's virus uses CCR5.
Fascinating. So you tailor the entry inhibitor to the specific virus type. And the strategy is generally using a combination of these classes, hitting multiple targets to keep the virus down and resistance low.
That's the cornerstone of ART, combination therapy. Usually 2 NRTIs plus an NSTI or a PI or sometimes an NNRTI. Oh, and we should definitely mention a critical application in obstetrics.
Ah, yes, pregnancy.
Prophylactic antiretroviral treatment for an infected birthing parent significantly reduces the risk of perinatal transmission of the virus passing to the baby during pregnancy, labor, or delivery. We're talking about reducing infant infection rates by at least 2/3, maybe more. This was a huge breakthrough despite initial fears about drug toxicity for the fetus.
That's incredible progress. Okay, let's shift our focus now to the nursing process and the clinical monitoring side of things. Arguably, this is the most essential part of long-term care for patients on these complex regimens.
Absolutely. Because these illnesses are so serious, the only usual contraindication to starting or continuing therapy is often a known severe drug allergy or a truly intolerable toxicity that can't be managed. So we always require a comprehensive baseline assessment before starting.
What does that involve?
Well, things like nutritional status, weight, vital signs, of course, but most crucially, baseline kidney and liver function studies, LFTs, and renal function tests. Because many of these drugs are metabolized by the liver or excreted by the kidneys, and especially when treating co-infections like hepatitis C, which is common with HIV, there's significant metabolic strain, particularly on the liver.
Got it. Baseline liver and kidney function is key. And the monitoring needed is often very drug-specific, right?
Highly drug-specific, yes. For example, with zidovudine, AZT, you absolutely must monitor the complete blood count, the CBC, very closely for signs of that bone marrow suppression we talked about.
Okay.
For patients on protease inhibitors, you need to assess for those physical signs of lipodystrophy and closely monitor their lipids, cholesterol, triglycerides, and their blood sugar for insulin resistance.
Right, the metabolic effects.
Exactly. If the patient is on Maraviroc, the CCR5 antagonist, or raltegravir, the integrase inhibitor, we need to assess liver function periodically and also keep an eye out for muscle problems, myopathy, or even rhabdomyolysis, which is a serious breakdown of skeletal muscle. Assess for muscle pain or weakness.
Muscle breakdown. What's that?
And beyond the purely physical, we must assess the patient's financial status and their support systems. This is a lifelong commitment. Adherence is everything. So ensuring they have resources for medication coverage, transport to appointments, emotional support, it's all vital for compliance and long-term success.
That psychosocial aspect is huge.
Right.
Okay, in terms of implementation and safety tips for nurses, the source stresses encouraging high fluid intake, like up to 3 liters a day.
Yes, unless there's a reason not to, like heart failure or kidney failure. Generally, encouraging good hydration, maybe up to 3,000 milliliters per 24 hours, is important. It helps maintain overall hydration, but also specifically helps prevent complications like nephrolithiasis, kidney stones. These are known to occur particularly with the protease inhibitor indinavir. Good fluid intake helps flush the kidneys.
Flushing the kidneys, good tip. Any other critical procedural details?
Yes, a very important one for IV acyclovir, used for severe herpes infections. It must be infused slowly, usually over at least 1 hour, maybe longer depending on the dose, and ensure the patient is well hydrated before, during, and after. Why? Because rapid infusion can cause the drug to crystallize in the kidney tubules, crystalluria, leading to kidney damage.
Yeah.
Slow infusion and hydration prevent this.
Slow infusion for IV acyclovir.
Got it.
And above all else.
Above all, patient teaching must emphasize strict, lifelong adherence. Taking all medications exactly as prescribed, consistently. Often these meds need to be spaced evenly around the clock, maybe every 8 or 12 hours, to maintain steady blood levels. Missing doses allows the virus to replicate and increases the risk of developing that dreaded drug resistance.
Adherence, 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 the absolute key. And we also have to stress the ultimate clinical reality, right? These antivirals suppress the virus, often incredibly effectively.
Suppression.
But they do not cure the infection. The virus, especially HIV, integrates into the host DNA and can remain dormant. So immunocompromised patients still need to be advised to remain vigilant, avoid crowds during flu season, practice safe sex, etc.
Absolutely. Suppression is not cure. That's a vital piece of patient education.
Okay, so let's try to boil this down. What's the bottom line here from Chapter 45? We learned that fighting a virus is fundamentally different. We're targeting processes inside our own cells. It means winning time for the immune system. And that treatment often involves these critical toxic trade-offs, like choosing between kidney risk, say with foscarnet, or bone marrow risk with ganciclovir for CMV.
Right, and we saw how the HIV arms race requires these sophisticated multi-drug combinations. Hitting the virus with drugs from those 5 distinct classes is necessary to try and beat its constant mutation rate, all while managing potentially serious long-term patient risks involving the bone marrow, the kidneys, the liver, lipid metabolism, fat distribution. It's complex. The complexity lies not just in picking the right drugs, but in managing the whole patient and supporting them through potentially decades of adherence.
Decades of adherence. That leads to our final thought for you, the listener. Considering that rapid mutation rate of HIV, and the really significant adverse effect profile of many of these antiretrovirals. Think about this. What are the biggest challenges facing the patient in achieving that lifelong adherence to a complex, multi-drug regimen? And how does the healthcare team strategically manage those adherence challenges? The side effects, the pill burden, the cost, the stigma over potentially decades of care. Something to really mull over.
The critical question for ongoing care.
Thank you so much for joining us for this deep dive into antiviral pharmacology, based on Chapter 45 of Lilley's Pharmacology for Canadian Healthcare Practice. From the Last Minute Lecture team, we'll see you next time.